Good afternoon, and welcome to the fourth webinar in our series on health literacy and chronic disease. My name is Catherine Maybury, and I'm a research assistant in the Horowitz Center for Health Literacy. So a few housekeeping details before we begin. After the webinar, you can request our slides at the link shown here. And then as an attendee, you're automatically muted. But if you have questions, please type them in the Q&A box, and my colleague Anna, who's monitoring the Q&A box, will relay the questions to me when I pause throughout the webinar. And then if you have trouble with the audio, you can call into the webinar at the number shown on your screen. So this webinar is one of 6 that the Horowitz Center for Health Literacy at the University of Maryland School of Public Health created in collaboration with the Maryland Department of Health. And the purpose of the webinars is to provide health literacy technical assistance to Maryland health departments and local health improvement coalitions in their work helping residents prevent and manage chronic disease. So the audience for the webinars is Maryland health professionals, staff, and students at health departments and local health improvement coalitions. And if you'd like to access our other trainings, you can visit our website here. So today's webinar, Designing Chronic Disease Programs that Address Health Literacy, focuses on best practices for designing chronic disease programs that serve individuals of all health literacy levels, including those with low to moderate health literacy. So people with chronic diseases have varying levels of health literacy, and this makes it hard to recruit, enroll, and retain people in our programs. And at the same time, we've been tasked with helping more people with moderate to low health literacy find our programs, enroll in them, and succeed. So considering health literacy in your chronic disease program design can help you achieve those goals. So I'd like to begin talking about why health literacy matters in chronic disease program design. So first, to meet the 2024 goals of the Maryland Diabetes Action Plan, we need to get more people who have diabetes into diabetes self-management programs and more people who have pre-diabetes into diabetes prevention programs. So the people that you serve are diverse, and they differ by their level of literacy, health literacy, by their health status, their age, the types of communities that they live in, their access to health care, and the specifics of their chronic disease. And all of this diversity really presents challenges in designing and delivering chronic disease programs. We also know from the National Survey of Adult Literacy that most people struggle to find, understand, and use health information to access care and make informed decisions. So as we design our programs, we want to keep these complexities in mind and keep health literacy principles in mind to reduce barriers that people might encounter when they look for information about a chronic disease program, or they try to enroll or participate in the program. So there's 3 objectives for today's webinar. At the end of the webinar, you should be able to discuss 3 ways in which low health literacy affects health outcomes, explain why you should consider participants' health literacy when designing a chronic disease program, and describe 3 ways to design your chronic disease program to address health literacy. So this is how we'll go through the webinar today. I'll begin by talking about why we should think about health literacy when we design our programs. And I'll talk about the link between health literacy and health outcomes generally. And then I'll talk about Maryland health statuses specifically. And then we'll spend the majority of the webinar talking about how to include health literacy in the different stages of program design. And we'll conclude with some resources to support you in this work. So let's start with why health literacy is important in chronic disease program design. So compared to people who have high levels of health literacy, those with low levels of health literacy use fewer preventive measures. So for example, they're less likely to have a colon screening, less likely to have a pap test or a mammogram, and they're less likely to have immunizations and be up to date on their immunizations. They have fewer routine physician visits, and they're less likely to have a primary care physician, so less likely to have a medical home. And they're less likely to be screened for diabetes, heart disease, and cancer. And in part, it's because they don't routinely see a provider. So people with lower health literacy are less likely and less able to manage their chronic disease, such as diabetes or heart disease. And there's lots of reasons for this, but some of the key reasons are they have a poorer ability to understand health information, health messages, and risks. So it's hard to manage a chronic disease if you don't understand the information that you find or are given. People with lower health literacy have poorer knowledge about their disease processes, their medication regimens, and their methods for managing their disease. So for example, they have more difficulty interpreting medicine labels, so they're not able to take their medicines correctly. And then when they're diagnosed with a chronic disease or illness, it's often later in the illness or disease process and has more serious consequences. They also have poorer digital technical skills. So they're less likely to activate and sign into their patient portal, and they're less likely to use any of the functions in the patient portal. And this is a problem because many healthcare providers often make information such as an after-visit summary or a test result or guidance available through the patient portal. So they're missing out on key information. People with lower health literacy are also more likely to have higher healthcare costs. So some of the reasons for this are they use the emergency room more frequently than those with higher health literacy. They have increased hospitalizations and longer stays when they go to the hospital, and they're more likely to be diagnosed with a serious illness. And then in addition to the financial costs, there's the human costs, like the pain and the suffering, their quality of life, their lost time from work, and then anxiety and depression related with managing and dealing with a chronic disease. So people with lower health literacy also have poorer health outcomes, and this is well documented. So some of those health outcomes are they have worse glycemic control, and they're less likely to achieve tight glycemic control. They're more likely to have higher rates of impaired vision. They have poorer blood pressure control, lower self-reported health status, and then seniors with lower health literacy are more likely to have higher mortality rates than those with higher health literacy. So when people don't have the capacity to access health information and services to make informed health decisions, they're more likely to have poorer health outcomes. And then finally, health disparities. There are significant health disparities associated with low health literacy. So research shows that those who have lower health literacy include people with limited education, non-English speaking, non-native English speakers, older adults, and some minorities. So we've just covered some of the associations between low levels of health literacy and several health outcomes. So now I'd like to talk about Maryland specifically. So many of you may already know that in Maryland, 1 out of 10 adults have diabetes, and this is about 500,000 people. And 3 out of 10 adults have pre-diabetes. And 5 out of 10 adults do not get enough physical activity. So what this means is we have about 7 out of 10 adults who aren't at a healthy weight and have pre-diabetes or diabetes. So we have a lot of work that we need to do. So those rates indicate that many Marylanders may not know about our diabetes prevention and management programs that are offered throughout the state, or they might know about them, but they might not sign up because perhaps they're intimidated by the process, or they might be anxious about things that they need to do. They don't have the knowledge to understand what's in the programs. So we want to design our programs to match the skills and abilities of those who have low to moderate health literacy. Because if we have a mismatch between people's skills and abilities in our programs, we can't serve as many people as we need to serve. We want to design our programs so that people don't encounter additional barriers when they go to join or enroll in our programs. So avoiding and managing a chronic disease is complex. So we expect people who have a chronic disease to do many things like take drugs, take tests, follow diets, follow exercise plans, and then make and show up for many healthcare provider visits. But sometimes we don't help them find or give them the information and tools to do all this work. So when we create our chronic disease programs, they're somewhat complex, and this is because of the complexities of managing a chronic disease. So what happens is many people don't come or they drop out. And those are signs that we're not engaging with our intended audience or program participants as well as we could. So we want to keep those complexities in mind and consider health literacy best practices as we design our programs. So now I'm going to begin to talk about different parts of the program, like how we can begin to consider health literacy as we design our programs. And we'll start with our primary audience. So our primary audience is health communicators and health educators. We often think about our primary audience. So we think about their age, their gender, where they live, their health status, and we might even think about their access to health care or health programs. We often measure people's knowledge, but we don't often ask why they might not know. And we rarely think about people's health literacy skills, meaning what they can do with their knowledge. So health literacy affects a person's ability to find your program, to sign up for it, and to fully participate. So we want to design our programs and think about our primary audience in each of the aspects of program development. So as we're planning a program, developing a program, implementing and evaluating, we want to think of who our primary audience is. And specifically, we want to involve individuals who have diabetes and prediabetes in these different stages and who have low levels to moderate levels of health literacy. Because the choices we make as a program developer and implementer affect people's abilities to engage and stick with our program. So we want to think about health literacy and consider the health literacy of our audience because individuals with higher levels of health literacy benefit more from our programs. They have higher levels of empowerment, they have better decision-making skills, they take more of an active role in the daily management of their chronic diseases. So we want to think about how we design our program so we can serve these individuals with low to moderate health literacy, so our programs become more accessible. So how do we consider our primary audience in our program design? Well, one of the best things that you can do is to consider health literacy in your needs assessment. So when you conduct a needs assessment, say you're collecting data, you might have a survey. So you want to make sure that your survey doesn't contain jargon and it contains language and sentence structure that people understand so they can actually answer your questions. And then if you conduct meetings and interviews or focus groups, you want to make sure, again, that your language doesn't have jargon and that people understand what they're there at the meeting to do. Because if our data collection methods aren't clear, then we're going to miss the input from these individuals. And then if you already have an existing needs assessment, you can add health literacy measures to it. And if you're creating a new one, you definitely want to include health literacy in it, in your needs assessment. And then one of the things as you're thinking about your needs assessment, you want to think about your staff's knowledge and skills related to plain language and clear communication principles. So that needs to be part of your planning. So now I'll begin to talk about program materials. But before I do that, I'm going to pause here to see if there are any questions from the audience.
There are no questions.
Okay, great. Then I'll continue on with program materials. So we assess, select, and create program materials using health literacy principles to meet the needs of participants with a wide range of literacy and health literacy skills. And we also do that to avoid embarrassing participants. So if participants come to your program and they don't understand something that the leader says, or they don't understand some of the materials, more than likely they may not say anything and they may feel embarrassment and shame. So we want to make sure that we create materials that don't cause embarrassment and that people understand. And then if we use health literacy principles, our programs can have a wider reach. So some of the principles that we really encourage is the use of plain language. So we use plain language so people can understand information the first time that they read it or hear it. We talked a lot about plain language in the first webinar. So if you weren't able to attend that, at the end there'll be a link to our webinars where you can get information about plain language. And then we want to make sure that our information is accurate. And the reason for this is that it helps build knowledge in our participants and it helps to support them in beneficial actions. And it's important to remember that our science-based information can be written in plain language. Just because it's accurate and scientific doesn't mean that it can't be written in plain language. We also want to make sure that our information is accessible. So this is important for written materials, for websites. So you want the material to be brief and you want it to, for people to quickly, you want to format it so people can quickly find what they're looking for. And some of the ways to do this are to use headers in bigger fonts, to use subheaders, to use bullets and lots of white space, and then images if they match your text. And finally, we want our program materials to be actionable. And the reason for this is that it helps people engage with the content. So what we want to do is focus on the behavior. So you want to tell people what you want them to do, and you want to give them the exact steps to do it. And it's important to break most activities into smaller steps to help people learn and adopt a behavior. We want to make sure that our materials are culturally appropriate because it builds trust and reduces the chances of misunderstanding. And it's important to remember that there can be cultural differences between the people who design and deliver programs. And this can lead to misunderstandings or confusion about actions. And this is sometimes hard to do. So sometimes if we have populations, say immigrant populations, we might need to go to that community and find someone to help us test our materials, translate our materials so that they are culturally appropriate. And then after you create materials, it's really important to pilot test them. And then you want to pilot test them, in this case, if we're talking about a diabetes prevention program, with people who have prediabetes or diabetes, and again, individuals with low health literacy to moderate health literacy. So you want to ask your audience, does this message make sense? Can they follow the steps that you're asking them to take? Can they use your tools? And importantly, do they have a suggestion how it might be improved or how it might be more helpful to them? And then you want to choose a format that's based on your audience needs. So, for example, web-based programs, we're all online now, are suitable for people who have digital literacy skills, but they're not that suitable for people that don't have those skills. So we want to think about how we can match our format to our audience's skills. And that's pretty challenging right now. And then the other thing is to consider more than one format for the information. So if you deliver talk verbally, you want to try and maybe follow that up with perhaps a written piece of information that may be available through email or a website, or you want to perhaps send them to a link to a video. So multiple formats support multiple learning modes for different people, and it reinforces the information that you say. And then finally, there's lots of resources out there. The Horowitz Center for Health Literacy has created these 6 webinars. CDC has many different, has a lot of information and many different tools around health literacy. And then if you're thinking about culturally appropriate materials and messages, the U.S. Department of Health and Human Services Office of Minority Health has a website called Think Cultural Health that has a lot of great examples. So before I go on to program development, I wanted to pause to see if there are any questions at this time.
Yes, 2 questions. One of them came through our Q&A about examples of questions to use in needs assessments around health literacy. And I typed out some potential example questions, including how often did your provider explain things in a way that was easy to understand? And where do you typically look for health information? There are questions in several federal level surveys, including MEPS, Medical Expenditure Panel Survey, HINTS, Health Information National Trend Survey, and CAPS, CAHPS, what it stands for is slipping me right now. But they have lots of questions around health literacy, patient-provider communication. And in the Healthy People 2030 objectives around health communication, there are some measures in there that you can use as well to, and you can map your county results to the federal levels. So those were some examples there. I just went ahead, Catherine. Sorry.
No, I thank you for doing that. I think that you got many of them. And then if you're trying to get in specifically, if you're dealing, say, with heart disease or diabetes, there can be some additional questions that you can ask specific to that.
And then the second, oh, go ahead.
No, I'm good.
Okay. The second question is, should we give our patient a test to see what their literacy skills are?
You know, there's a lot of discussion back and forth, but the general rule is no. And there's several reasons for that. First, for many people, especially for patients, they feel it's just one more test. And then there's that sense of being tested, and perhaps if you have low literacy, feeling like you failed it. So there's the issue of feeling like you're tested. So then the question is, well, how do I get around that? And one of the best ways is to design your materials using what we call universal precautions, so that you've written a material that everybody can understand, and even people who have higher levels of health literacy can benefit from reading something that's easier to read. So, no, we don't recommend you test. Sometimes we do that in a research setting, but the other thing that can happen with that is if it ends up in a chart, then again, there can be stigma in how people treat people. So I think it's best to go at it from a universal precautions approach, and thinking about creating and talking in ways that everybody can understand, and then confirming understanding.
Yes. And then the follow-up to that was, should they go in a separate class from the people with higher literacy?
I think it really depends, say, how many people that you have. We're really let's just say you have a really large number of people, and then you could segment your class. You could offer multiple offerings. But then again, if you were going to segment people, you'd kind of have to know, right? You'd almost have to do a test. So what we're really suggesting is that you use universal design principles, and we're going to cover some of those so that the materials are understandable. But, I think the hardest part there is if you were to do if you were going to segment people, you'd have to know. And the only way you could know is by testing, because many people, you can't look at someone and tell their health literacy. You might make assumptions by the way they talk or the way they dress and think that they have higher health literacy, but many times that's not accurate. So people might have good verbal or oral literacy and not reading. So we really want to use that universal approach, designing for everybody.
Thank you. That comes from me and from the person who asked that.
Perfect. Okay, so now we'll talk about program development. So when we develop a new program or we modify an existing program, we want to use science-based theory or models or frameworks. And the reason for this is that theories and frameworks can help explain behaviors and the context in which they occur. And they provide an evidence-based approach to help people change behaviors. So there's lots of behavior theories out there, especially I know that health educators know about a lot of these, but health literacy might not be a part of your program models or frameworks. So what you want to do is look at the literature for intervention examples that have looked at health literacy. So we include health literacy in our program models because health literacy is part of an evidence-based approach. It helps explain people's attention to and comprehension of your program. And it helps explain why people may not follow through on recommended behaviors, things that you've suggested that they do. And health literacy is part of the context in which behaviors occur. Their health literacy affects a person's ability to engage in a behavior. And just as an aside, the diabetes prevention program used a mix of behavior change theories. So for example, they used social cognitive theory, which is individual behavior in a social setting to support goal setting and self-efficacy. They use the stages of change, or the trans-theoretical model, to assess readiness to act on a new behavior. And then the theory also provides strategies to guide that change. And then third, they use the theory of planned behavior to support program activities related to attitudes about the risk for diabetes and intention to make behavioral changes. So what we want to do when we're designing for health literacy skills is understand our participants. We want to understand what they want and need from our programs. We want to understand their health literacy skills, and we want to support participants' need to be successful. And then with that information, we can create messages, materials, and activities to match low and average health literacy skills. And one of the things you want to think about is perhaps pay attention to prior problems, say with low attendance at a program or low interest in a chronic disease program. It's possible people didn't understand the program or how to enroll or even why they should care. And then with this information, we do want to create, as I said, messages, materials, and activities to match the individuals in our programs. So after we've created our materials, we want to test them, the materials and the activities, with the participants. So in this case, it means people with, if we're talking about diabetes prevention, it's people who have prediabetes or diabetes. It's people who have low levels of health literacy. And then what we want to do is assess specifically as we're going through the program. So a lot of times we'll test our materials when we develop them, but we want to continue to assess people's understanding of our materials and activities throughout the program, because it can make sense up front to one group that you might pre-test it with, but then as you go through the program, you'll find out that, oh, I could improve that or enhance that. And then we want to use that information to refine our program materials and activities. And then as we're developing our program, and I had said this a little earlier, you really want to think about the training that the people that will be delivering the program have in communication principles and health literacy design principles. Because you could develop a program and it could be, say, free of jargon and plain language, be actionable. But if the person who's delivering the program is not trained in clear communication principles, they may not deliver the program as you had intended it to be delivered. So you just want to be cognizant of your staff's training. And then CDC's has some great trainings on health literacy and interprofessional collaboration. So I recommend that you check out their online learning system. And then we've talked about this before, but if you're creating materials, the CDC's Clear Communication Index is very helpful in figuring out if you have a clear message that your audience will be able to understand. And the key there is up front defining who your target audience is. So before I go into program delivery, I wanted to just see if there were any questions.
There are no questions right now.
Okay, great. So when you talk with your program participants, whether that's one-on-one or in a group or through a Zoom or some sort of virtual session, when you're delivering that information, you want to make sure that we're going back to plain language and speaking slowly. We want to limit the amount of information. We give it a time. And then we want to use relatively simple sentence structure. We don't want to have, even with our oral communications, we don't want to have very long sentences or paragraphs or speak a lot because that burdens the person who's listening. And then as we're communicating, it's really important to confirm understanding. And we've talked about Teachback before. So what Teachback helps you do is confirm that you, as the leader of the session, have explained information and actions in a way that your audience understands. So if you ask a participant to explain to you how they will do an action at home, and say, let's say they get 80% of it or 90% of it right, you want to focus in on the piece that they are not clear on, and then you can paraphrase, you can reteach that through paraphrasing and rewording it. And then you want to, if you have multiple sessions, you want to be able to go back and review, because reinforcement is part of learning. We need to often hear, all of us, when we're learning something new, hear it multiple times in multiple ways. So I'd also like to talk about program delivery modes, and a lot of this is brought about by our current environment. So as we see it, there's three types of program delivery modes. There's in-person, online, and hybrid. And the important thing here is that each mode can either expand or it can limit program access depending on your audience's literacy, digital literacy skills, and their resources. So if we talk about an in-person mode of delivery, this was probably the typical delivery for many of our programs, pre-pandemic. So the benefits of this type of program, say compared to an online delivery mode, is it's easier to connect and develop trust and rapport with people, program participants, and it's much easier to read nonverbal cues than it is, say, through a Zoom session. So it's also easier to see if people understand what you're saying. So when you're in person, it's much easier to see those quizzical looks on their face, or their eyes glazing over, or the question marks, that they're showing you. And then it's also easier to demonstrate actions and have participants then demonstrate that back to you. It's easier to look at information they might bring to class, a food log or a blood pressure log. So it's much easier to look at those things in person and see things that you might not catch online. And then it's easier for participants to meet and build community. But the downside is that people might not be able to come to your program because of distant time. They might have other responsibility like babysitting. So, there is that advantage. And we have been seeing some people that their online program, they're reaching more people through their online programs. So when we talk about an online program, they allow us to deliver programs when we can't deliver them face-to-face. So it can allow, in some situations, more people to join your program because they don't have to think about getting off work or babysitting. And it can be more flexible, especially if some of the materials are made available, say, ahead of time for them to look at. The downside is many people don't have digital capabilities or the skills to join the meeting. And they might have competing demands at home. We've all been in work calls and Zoom sessions where there's all sorts of activity in the background. And then it is harder online to develop and build and connect community. It's harder to assess understanding and engagement, and it can be a lot more work for the instructor to have to rethink how you've created activities to do them in the digital world. And I would just say we're all learning. So be brave, try things, and if they don't work, you can adjust it later. And then the hybrid model can be more flexible. So especially if some of the materials are made available online or ahead of time, then you can spend the face-to-face time more effectively. So you can demonstrate actions, you can answer questions. And the good news about a hybrid model is it can support multiple learning styles. Some people learn better when they're able to process things offline and come together. And there is more engagement in the hybrid program than there is in an online only. But a hybrid program has the same negative or downsides as an online program in that you have the issues of digital technology and skills. And this is of both the participants and sometimes the program leaders, and you have to rethink your activities. So if we deliver programs online, and this comes back to a question earlier, our community health assessments do need to collect data about the community's access to technology. So for example, is there broadband or internet? Is there Wi-Fi? How reliable is it? So we want to also think about how we might be able to reach out to people who have limited access. And we know that this is a real challenge for people in the more rural areas of our state. And then smartphones. So they have their upsides and their downsides. So the positive is if people are familiar with the technology, then they can download apps. But they need to have Wi-Fi, they need to have data plans to be able to do that. The downside is people often share a mobile phone, so it's not just one person, so they may not always have the phone with them. And they may not have the latest generation of a phone. So if you just develop a material, you want to think about the mode that you're going to deliver it in when you develop your materials and activities. So sometimes, people might have a smartphone that's 3, 4, 5 years old, and it doesn't support an app that you've written today. So you absolutely have to test that out. And then I want to focus on just a few more areas here when we're delivering our programs. So we talk about when we create actionable information that we want to break information down into its component parts. And this helps people learn and master new skills. So I have on the screen here nutrition facts label from a bagel. So we see that the bagel has 330 calories and 63 grams of carbohydrates. So if we're trying to teach people how to read a nutrition label to figure out, like they should have maybe half of that bagel, then we want to break it into smaller tasks. So that might be showing them the label, explaining the different parts of it, then like where to find the carbohydrates, where to find the fiber. We need to teach them portion size, and then how to calculate the amount if we're changing from what the serving size is there. So if I'm going to eat a half a bagel, then we need to teach them how to, do math. They'll have to divide it in two. So we can't just say, well, read the nutrition facts label. We want to break that down into those component parts. And then we always want to demonstrate actions. We want to demonstrate exactly how to perform an action. So if we're teaching food portion sizes, we want to give specific examples of different foods. So we could use something like the choose my plate, or if we're talking about protein, then we can have sample packets or sizes of, how big you can do this with like rice or grains, like how big something might be. Or you could have a deck of cards to say this is about 3 to 4 ounces. This size of a portion of chicken or fish would be to 3 to 4 ounces. So you definitely want to demonstrate the actions. And then we mentioned this before, we want to reinforce spoken information with written information. So we can use pictures, drawings, models, and this all helps reinforce the information so people can learn it, remember it, and master it. So before I go on to program evaluation, are there any questions?
Yes, one question and one comment. The comment is, this person says, sometimes I have another class member explain to the individual who doesn't understand, and 9 out of 10 times that works. So I would encourage, or the person is encouraging using the people in the group class too.
Yeah.
Go ahead.
I would say that's a great tip because they're hearing it from another person, perhaps in slightly different words, and hearing things sometimes, you're somewhere and someone's educating about something and it's not until you hear it the second or third time that you go, oh, okay, now I get it. So
Right.
That's a great tip.
Right. One of the questions is it okay to ask your patient or your participant to give feedback on what I said? I typically give scenarios in the class.
Scenarios are great, but like we encourage, especially, well, anytime, but often in the medical environment, we encourage. It's one of the ways that you can confirm that a patient understands something. And you can say something like, I've just gone over a lot of information. Can you tell me what you'll do when you go home to explain this to your partner, spouse, that kind of thing? So I think it is important because a lot of times people, shake their heads like, yes, I get it, but then they walk out and they didn't get it. So I think it's really important to confirm understanding because otherwise it'll just, you might think that they understand it, but then it shows up in they might not be taking their medications properly. They might not book that follow-up appointment like you asked them to do. And you wouldn't know that until they didn't do those things.
Got it. Thank you. And then one question, Catherine, do you know of any grants to help develop low literacy materials? I am not aware of any, but I don't.
I'm not aware, but I'll take that as an action item, and I'll look into that, and I'll talk to some folks in our center, and we'll post that back out.
Okay. No other questions.
Okay, great. So now I'd like to talk about program evaluation. So a really important part of program design and implementation is the evaluation. There's lots of frameworks and for program evaluation, and we're not here to tell you which one to use, but we want to recommend that when you're evaluating your program that you include health literacy measures, and they would fall into 2 buckets. So the first one, you want to have measures related to your program participants. So you want to figure out, like, what are my measures? Do I want to increase knowledge? So would I do a knowledge test? Do I want to increase skills? So I would have them demonstrate skills. Would I want to know about behavior? So you want to figure out measures related to the program participants. And then you want to think about your program as well. Like, what are the goals of it? Is it to remove barriers? Is it to build health literacy skills? So for example, for your program, are you trying to get more individuals into your program? Do you want to remove barriers to enrollment? So there's, you want to think about those two pieces. And then when you've thought about your measures, you want to figure out what are the data sources for those measures. For example, is it a self-report survey? Is it observation in a group? Is it interviews? That sort of thing. And then once you figure out how you're going to collect the data, you want to determine who's going to collect the data. Will that be program staff? Will be that through surveys? So we want to, just consider that as part of like adding it into our program evaluation. And then there's lots of different program evaluations out there, but I'm just going to talk generally about health literacy, how health literacy fits into program evaluation. So there's three parts to when we think about health education planning and implementation, program planning and implementation, we think about formative, process, and outcome evaluations. So your formative evaluation, when you're developing your program, so you want to kind of check yourself and say, do you include input from members of your primary audience or target audience who have low and average health literacy skills? And how is that input captured and used? Because that would help drive the types of things that you design and implement. And then for your process, where you're assessing whether activities are delivered as designed, you want to make sure that you assess the activities for individuals with low and moderate health literacy. So the kinds of questions you might ask there are the instructions that I've written clear? Can participants follow my instructions? Can they do the activities that I've planned as intended? And do they learn what you intended them to learn from the activity? And then for your outcome assessment, you want to think about, do participants with low and average health literacy have the same success in your program as those with higher health literacy? And did you recruit and retain participants with low and average health literacy at the same rates as those with average to lower health literacy? And then based on your assessment, you can use these insights to revise your program to respond to your program's needs and to drive your program forward. So now I'd like to talk about some participant needs. So there's lots of things outside of your program that can prevent participants from being successful in your program. So there could be a lot of costs. So for example, program fees, costs of healthy foods, costs of medicine, costs of childcare, transportation, their exercise choices. Do they live somewhere where they can exercise safely? And their digital devices. Do they have digital devices? So some of the kinds of questions that you could ask include things like, what makes it hard for you to care for your health? What are your priorities right now? So they might be in your program, but with COVID, they might have a lot of other priorities. So participating in your program is not their highest priority. Or you could ask them, how easy was it for you to get here today? You can ask them, do you have trouble getting healthy foods? You could review their insurance coverage to see if some of the program costs could be covered by insurance. And then you could assess other needs and then try and identify other community resources to make referrals. And then a really great question to ask is, do they get their questions answered in the program? So some more participant needs. So social support. So this is really important for people trying to make a behavior change. So we might want to ask them, who does the food shopping and meal prep? Are friends and family supportive of and helping you with lifestyle changes? Because we know that sometimes people sabotage people that are trying to make these changes, or they're not as supportive as they can be. And then, do they receive positive comments from their healthcare providers? We've heard from some of the work that we've done that people are doing all this great work, but their healthcare providers don't really acknowledge it. And then other considerations are, how are your individuals motivated? Are they motivated, are they self-motivated? Or are they motivated by participating in a group program? And then, are they comfortable sharing information in a program? For some people, sharing is something really personal, and they're just not comfortable. So in summary, when you design your program and think about health literacy, it can help you create a program that reduces barriers for people to find and join your program. It allows you to reach a broader audience. It increases participants' understanding of your program materials and tools, and it makes it more likely that participants can take actions to prevent or manage their diabetes. So now I'm going to talk briefly about resources. So the Centers for Disease Control and Prevention have some really great information and tools. So there's a link in the presentation to CDC Health Literacy. They also have trainings that we've talked about that are free for health professionals. We've talked about the Clear Communication Index for developing materials. And then for those of you who are interested in some of the science and the interventions, there's links to a couple different systematic reviews. So a systematic review goes out and looks for, has inclusion criteria around studies and interventions. And so there's some interventions that have been successful incorporating health literacy. So we've included those. So this was our 4th webinar, and next week on the 9th, we will have a presentation on tips to create more engagement with diabetes programs. And then we'll conclude with what diabetes educators know about periodontal disease and diabetes. And that will start at 3 o'clock. The last 2 will start at 3. And then before I take questions, there is a post-evaluation webinar. We would love your feedback. You can join our email list. You can request today's slides. And then we'd love to hear from you. You can reach us at healthliteracy@umd.edu. So that's the end of our presentation for today. So I'm wondering if there's any questions before we end our session.
There are no questions. Several thank yous from attendees.
Okay, well, we're so glad you could join us, and good luck in the work. You guys do such great work out there, and we look forward to having you join us next Wednesday. Thank you.
Thanks, everyone.
Okay, so I'm trying.